Good morning, everybody. Welcome to the Readmissions and Care Transitions Community of Practice. This is Kate Carpenter, one of the Quality Improvement Advisors for the Compass HIN, and I would like to thank you for joining us this morning. As you know, last month we launched into a summer series on age-friendly health systems, and in today's session, we're going to have an opportunity to learn more about how preventing readmission starts by providing a safe and healing hospital stay the first time around. We know, of course, that this can be a challenge when caring for our older adult patients who are already sensitive and fragile. The caregivers can really rise to the challenge by implementing concepts found in age-friendly models of care and by heightening our knowledge of the inpatient harms that can occur in our older patients. I'm going to start by going through just a couple of housekeeping items this morning. If you could, navigate to the chat box. We'd love for you to type in who's in the room today. List for us your name and your facility and perhaps what role you're in. We'd love to see who's joining us. Take a moment to mute your phone line if you haven't already. This kind of helps us eliminate any background noise during today's presentation. As a reminder, if you've dialed in and need to step away, please don't place the call on hold, as we often will hear your hold or background music. As always, we do encourage your questions and open discussion. Staff will be moderating the chat throughout this event, so please utilize the chat box to type in your questions and comments as they come up, and Larry will be happy to address those. At this time, I would like to introduce our presenter for today, Larry Newman. Larry is the Assistant Professor and Director of the Primary AGNP program at the University of Iowa. Larry is a board-certified adult and geriatric primary care nurse practitioner, and he received his DNP from the University of Iowa in 2013. Larry's practice focuses on primary care for geriatric patients in the rural nursing homes and also includes work in primary care, as well as geriatric special needs dental clinic. Larry, it is a pleasure to have you join us today. The mic's all yours.
Thank you very much, Kate. I appreciate it. And thank you for giving me the opportunity to present on this topic that is so very important. So I see a couple people have typed in, Anne has, and then Van Buren County Hospital. I would be really interested to see where else everyone is from. So if you haven't yet, and am I the only one on video? I don't see anyone's face except my own up here. I thought I'd be seeing like a pool of faces. So if you have a camera, turn it on. I'd love to see you. So what I'm going to talk today, the title of the presentation is called Building a Case for Improved Care for Older Adults, Models of Care. And it really should say models of care that you can implement to prevent adverse conditions from occurring. But that was a little too long, so we just shortened it to models of care. So what we're going to talk about today is those adverse conditions that our elderly patients will face when they come into the hospital. When I say elderly, I'm referring to people over the age of 65, and then I would probably call frail elderly over the age of 85, though you can have a frail elder who is 68, depending on how many comorbidities that they have and such. So I really like interaction during this, so I'll be asking a lot of questions. So be ready at the typewriter or with your voice. You can unmute yourself and answer the questions as we go along. See, we have Marshalltown here also, and Emily Laws from Fort Madison. Great. And Montgomery County Memorial Hospital in Red Oak. Excellent. So just a little bit more about myself. Kate was nice enough to introduce me. I just wanted to mention this project that I'm working on. It's a year-long project where I go into the College of Dentistry here at the University of Iowa as a primary care, gerontological primary care nurse practitioner. I bring a student with me, and we go into their special needs geriatric clinic that they have every day. We go in on Thursdays, and we are testing out having a nurse practitioner present to help address issues like blood pressure, uncontrolled diabetes, because what happens is they show up at the dentist and then they can't get their work done. because their blood pressure is out of control, and they're usually just sent away on their own, but I can address that immediately. But I just thought it was an interesting project that we're working on, kind of the interdisciplinary thing. And you're going to find some of these models of care that we talk about today have a lot of interdisciplinary aspects to it. And I really believe, I'm a strong advocate of that, that really to be successful, we all have to be working together and not in our separate silos. A little more about me. I have a background as a nurse, a burn nurse at the University of Iowa, and then I became a nurse practitioner in 2013. Do we have nurses out there? Are anyone out there that's listening a nurse? You can either speak or type it in. RN here, Lana's a RN. Great. Anne, you're an RN. So I only ask because some of the language I use might be a little nursey, and I've really tried to kind of not make it so nursey. So if you catch me saying something that perhaps someone who isn't a nurse wouldn't catch on to, please jump in at any time. So we're going to talk about today, first of all, just general information about the aging population in the Midwest. We're going to talk about the different adverse outcomes that can happen to people, elderly people who are admitted into the hospital. And then we're going to talk about the different models of care. And I'm hoping that some of you have some of these implemented and we can hear from you about what you might have going on in your hospital. So we go to the next slide and we'll just talk about basic demographics. So the next slide has, on the left side, it's the percentage of population. This is for the aging of the baby boomers. And then at the bottom is a 15-year period from 2015 to 2030. So they estimate that those between 65 and 85 years old, it's going to go from 14.9 to 20.6% of the population. But those greater than 85 years are going to more than double between 2015 and 2030. And those are the frail elderly, and those are the ones who are most at risk, as you all probably know, that are most at risk for these adverse situations that can come just from going into the hospital. The issue here is that most hospitals don't have geriatricians on staff. And I think, well, that's kind of an ongoing theme we'll talk about as we go through here. And we'll talk about how hospitals have kind of gotten around that, or they've implemented, creative ways to access geriatricians. So that's something you want to think about for your hospital. If you don't have a geriatrician on staff, let me ask you this. Who here does not have a geriatrician as a hospitalist or on staff for inpatient?
Well, I don't.
You decided not to respond? You can type it in. So VBCH does not. So do you have hospitalists, Dixie? You can speak too if that's easier. So you have hospitalists on staff, but they're not necessarily trained to be a gerontologist or a geriatrician. And I think that's a theme that we'll probably find a lot. So we can go to the next slide. And that's what we're talking about for, is your hospital prepared? So it's estimated that 12.3 million inpatient discharges per year are attributed to elderly patients, those over the age of 65. There are approximately 56,000 hospitalists now, but many receive little to no training in geriatrics. And then many hospitals are without geriatricians. So we already talked about those who don't have a geriatrician on staff. Is there a hospital out there that does have a geriatrician on staff? And if so, can you name one benefit of that? You can speak. I would love for someone to, I know it's hard to unmute that thing, but I would love to hear from you. All lines are unmuted, so you would be able to speak now if you weren't being heard before. So who out there has a geriatrician on staff?
You are spending way too much freaking time worrying about whether or not there's a geriatrician on staff.
I am? Oh, you should have muted that. That was probably a comment that you should have had muted. So, next slide. Can we go to the next slide? Great. So preventing specific adverse outcomes. Hospitalization for the older adult patient can result in unintended adverse consequences from interventions meant to be therapeutic. Well, what does that mean? Who can, probably one of the nurses can tell me, what's one intervention that we could do that you or I, if it were done to us, we probably wouldn't have any issues with it. But someone who is 7 years old, if that intervention, they get admitted to the hospital, what could it be? Restraint use, good, Lana. That is one. Restraint use, because the skin of the elderly patients that we have is much more fragile. That is one. Some other things are IV. Just the tape alone on an IV can cause some issues. And urinary catheters, you know, the UTI or the COTIs that we have in hospitals, that everyone, I'm sure, is aware of that and is working towards getting rid of that. Those are different therapeutic interventions that for someone who's elderly could cause an adverse outcome. Bed rest. Why would bed rest be cause an adverse outcome? Anyone? All right. Decondition. Reduce mobility. So decondition, thank you, Dixie and Lana. So decondition and reduce mobility. Decondition comes about for longer term. Blood clots is another one. Makes them at higher risk for blood clots. It increases their risk for falls. Skin breakdown. If you have an older person on bed rest, they're at higher risk for skin breakdown. So these are things that perhaps a geriatrician would be aware of as they're treating patients, but not necessarily a general hospitalist would think of in regards to someone who's 87. So the pearl, we're going to have pearls throughout this presentation. Avoid activity order for bed rest until absolutely medically necessary. That's something that would benefit someone who is older. We can go to the next slide. We're going to talk about the first adverse outcome, and probably the most important one, and something I bet all of you focus on, and that's falls. And I would bet that everyone screens for fall risks as when your patients come in. And then the environmental hazards like wet floors, overcrowded rooms with furniture, and proper toilet seats. So what does that mean, improper toilet seat? What, for someone who's older, what can you do to assist them and keep them safer as far as toilet seats and beds go? So toilet seats, dark colored seat, and handrails. I'm not sure what you mean by dark colored seat, Lana. Can you unmute, Lana, and speak to it? Would that be okay?
Good morning. Can you hear me okay?
Hi, thanks.
So when I'm referring to the dark colored toilet seat, just for visual impairment, sometimes the white seat and the lighter colored floor can create a perception where the depth perception that's lost is problematic for an elder. So
Perfect, great.
Seat,
that's a really good example of none of us is smarter than all of us. So that's really why I like you guys to bring this in, because I would not have thought of that as an example to use. But yeah, for visual acuity, if you have a different color, then they can differentiate. And what I was going for, your answer is absolutely correct, but I was going for the raised seat. A raised seat on a toilet or a higher bed helps an older person be able to stand easier, and it keeps them safer and it keeps them from falling. So that's a really great example, Lana, thank you. So some other pearls about falls. Falls are less likely with a vinyl floor than with carpeting. It's recommended by the American Geriatrics Association that vitamin D supplementation for fall prevention be used in the nursing home patients. And that's really for not fall prevention, but fall injury prevention. So it's recommended that we give them vitamin D so that their bones don't break as easily. That's what that is talking about. And then delirium prevention is a proven strategy for reducing inpatient falls. Delirium is a big topic, and we're going to talk a lot about that a little bit later. But let me ask, is there anyone out there who's had a relative fall, a mother or a grandmother or father out there that has fallen in their home or in the hospital? So Dixie, you said yes. Do you mind just sharing with us kind of what happened with that fall? Can you unmute Dixie? You're unmuted, Dixie. Oh, no mic. Okay, that's okay. Then just type it in. So broke 7 ribs. And how long was their recovery? Was it days, weeks, months? Months, right? If you and I fell and broke our ribs, it would hurt for a while, but we'd still be able to get up and do our activities of daily living and go along with our life. When someone is older, the reason we're so focused on falls is because when they break a bone, it takes them much longer to recover. And during that recovery, they are subject to so many risky adverse events. From skin breakdown to blood clots, all of this. So I bet all of you know of an older person who has fallen, and it's usually breaking a hip. And they end up in the hospital, and then they have to go to a nursing home. And sometimes it's kind of the beginning of the end for them. A lot of times it's the beginning of the end. So that's why we really focus on fall prevention for older people, is because of that bone breaking and the long time it takes for it to heal. So that's the first one we're going to talk about. We can go to the next slide. Another issue when patients get into a hospital for everyone, but it can be especially troublesome for an elderly person, is sleeplessness. So you get into an unfamiliar sleep setting, you're not feeling good, you're in pain, or you're feeling short of breath, so you're not able to sleep. There's noise going on, there's lights going on you're not used to, there's an IV beeping next to you, you'll have visitors to the patient next to you talking, and the logistics of providing the care, so getting their labs, doing the blood draws, and giving them their medications can sometimes cause problems. Sometimes providers will write a prescription for medication every 4 hours. Well, if it's every 4 hours, that's every 4 hours. But if it doesn't say while awake, they're going to wake them up, or they're going to give it to them and wake it up. If they're giving them a shot, they're going to be woken up, so they're not going to get good sleep. So inadequate sleep, whether it's too short duration, of poor quality, or interrupted, may contribute to a host of complications. So older hospitalized adults who received multi-component intervention. So what that means is protocols that address sleep deprivation have a decreased risk of developing delirium. So multi-component intervention, meaning that there are different things that were put in place. So they do this next one, the Pearl. You bundle care at night. So the nurse comes in and they bring their medication, they toilet them at the time, they take all their vitals, and they do that before bedtime, and then they let them sleep a good solid amount of time. So if you can make just minor changes like that, sometimes it's not possible. Sometimes you have to do blood pressures every 2 hours because of the condition. But if it is possible to bundle everything, give them time to sleep, and then move on, then start it the next morning, back up with the vitals and meds, then that's what you should do. Next slide, please. Another thing that can cause some issues is tethers. So catheters, that's urinary catheters, IVs, cardiac telemetry leads, and restraints. So these are all associated with increased rates of delirium, infection, and falls. So what can happen is a older person can come in and be a little confused. And so what are they going to do, nurses out there? You have them on, you're giving them some fluids. They get confused. What's the first thing they're going to do, nurses? Pull out the IV, right? They're going to go right for it because it's something foreign. They don't know. So what do we do then to keep them from pulling out their IV? What's the next step? There's a couple of different options you could put out there. You could wrap it in Coban, right? But they might still get the tubing itself. That would kind of keep the IV safe and in place if they're moving around a lot. But if they're pulling on it, we're going to restrain them, or we're going to bring a sitter in, right? So restraining costs money because you have to. It costs more time for the nurses to go in. They have to do checks, you know, every hour, every 2 hours. If you have a sitter, you have someone come in. So now you have an older person with an IV, and now they're tethered, they have fragile skin, and they're getting more and more confused because they're in an environment they're not aware of. So what we recommend is that you, to reduce the risk of delirium, is that you try to reduce these when possible. Another example I can give is for cardiac telemetry leads. So these are put on people to keep an eye on their heart rate and their heart rhythm, right? But if you have an 87-year-old in your hospital who's a DNR, and this is a question for all of you, if you have an 87-year-old who's a do not resuscitate, do you need to have leads on them, telemetry leads? What do you think? Yes, no, or maybe? I would love if more of you participated. "87-year-old patient, do not resuscitate, in the hospital." So it depends on what kind of treatment they want. Good. So Dixie went for what does the patient want? Need to have end-of-life care discussions. Good. Okay. So you need to have end-of-life. If they're a do not resuscitate, then you've probably had those discussions already. My point being is, if they're a DNR, there's no reason for us, in some circumstances, to have the nurse watch their rate. There are times that you do, if they're there for an acute issue and it's curative and you're gonna try to fix them, then sure. But if they're a DNR and that is a possibility to reduce tethering, is by not putting on those telemetries. Another thing is we really encourage nurses not to keep urinary catheters in place. What's the maximum time? When I teach nurses, I teach them a maximum time a urinary catheter should be in after surgery. Anyone want to guess? 2 days. Thank you. 24 hours or less. That is what I teach people, is 24 hours or less. So you may have a policy different than that, but that we want it out as soon as possible. The longer that urinary catheter is in place, the higher they are at risk. And Emily, thank you for responding to the last question, and that's the reason for being admitted. If they're in AFib, so atrial fibrillation, so their heart is not beating regularly, and that's their reason for admission, then yes, right, you would want to watch that AFib with the telemetry. All right, we can go to the next slide. So another issue that comes up is infections. C. diff. What does C. diff stand for? Who can spell that out? It's really hard. And this is the reason why we call it C. diff. Someone type that out so everyone can see what it really stands for, and I'll keep talking. So C. diff is an issue. Pneumonia, a spelling test, right? You didn't know you were here for a spelling test, right? C. diff, Clostridium difficile. That's why we call it C. diff. It's Clostridium difficile. So that's one infection. Another is pneumonias for older people, especially those with dementia. If the pneumonia can be due to inhaling their food or aspiration pneumonia, UTI infections from the catheters, and then IVs, putting an IV in and leaving it in too long, or that can bring about an issue of infection. So the pearl here is infection control programs aim to reduce the rates of nosocomial infection. So nosocomial means the infection started in the place where they're at, so in the hospital. Hand washing, which is the last bullet point, I probably should have put first. So that's the #1 thing we can do. Do you have hand washing surveillance and where you guys work? Do you have people kind of count how many people, watch them going in and out of rooms? Any hand washing surveillance out there? So they do. Jamie does. Dixie does. Jenny. Yeah, nurses are not always really friendly towards those people. They feel like they're double checking their work. But it is an important thing to do, because that really is the #1 way to reduce infections. But other things are just the standard universal precautions, and that means that you're wearing gloves, you're wearing a gown, you're wearing a face mask when it's appropriate. Isolation precautions when appropriate. The thing is, when you put in an elderly person into isolation, then you put them at higher risk for delirium. And then our environmental cleaning can help with infections, the surveillance we talked about, and then the hand washing. We can go to the next slide. And we'll talk about delirium. So we don't always know the cause of delirium in older patients, so we can't always make changes to prevent it, but a lot of times we do. What do you think are some things that might cause an elderly person to become delirious while they're in the hospital? Good. Infection could. So dementia is different. So dementia is a long-term confusion. Delirium is an acute that comes on suddenly. So dementia comes on slowly, and then delirium is different. So you can have someone with dementia that has delirium, but what causes it? You have medication interaction, good. Dehydration, perfect. Those were the exact answers I was looking for. Change in their environment, yeah, but that's something we can't necessarily fix. But we can fix dehydration. We can fix medication interaction if we know that's what's causing it. So we can look and do a medication review, see if there's anything there that might be the cause of this. So delirium is common, up to 56% of incidents in hospitals, and it's deadly. It is life-threatening. Studies have shown that a lot of people that there's you get delirious in the hospital, your risk of dying within the next year increases. I don't know the exact percentage, but a lot. It's also expensive, $2.5 million per 1,000 cases. It is potentially preventable, as I said, and it's potentially reversible, but sometimes it's not. The best thing we can do is prevent it in ways that, look for ways to prevent it. And then we can talk about some delirium prevention pearls on the next page. So it shows that if there's interaction, if they have a daily visitor, so if they have activity, if they have family members present, music, newspaper, iPad, pictures, if they're kept busy or they're interacting, it can help reduce delirium. Hearing, making sure that they have their hearing aids in place with batteries. So, you know, sometimes they have them in and the batteries are dead, and they won't always tell you, as nurses know. But you want to check with the family, make sure they have good batteries there. There's no earwax, and then communication techniques can be writing down or making sure that you have a board in the room that's written in big letters about, you know, the date and that type of thing. Vision, visual aids, adaptive equipment, large print, and large button phones. Anyone here have parents or grandparents who you've had to take their television remote and like tape over every button except for 3, like the on, off, and channel and volume? That would be 4. Anyone have that? Anyone want to share? You are not a chatty group. I'm waiting. No taping, but what did you do instead? You had them use headphones. So for their TV, because they had to turn it up really loud is what I'm guessing. I bet they had to turn it up very loud, so you got them headphones so they didn't, so the neighbors weren't listening to the 6 o'clock news. Is that what it was?
Yeah, yes.
Exactly. Right, yes. So older people will turn their TV up way loud. So to help them hear it better and to help those around them not hear it as well, you got them headphones. Good. So doing things like that, especially if they have a roommate, you could get them headphones. That would be helpful for everyone. So delirium prevention, also fluid repletion, just means giving them fluids. So you push fluids, you encourage oral intake of fluids and assistance with them if they need assistance drinking. I can tell you in some nursing homes that I work in, every day at 2 o'clock they play Little Brown Jug, and that's a reminder to everyone who's cognizant and can recognize it to take a drink of water, and to staff to give a drink of water to those who might have dementia to help prevent dehydration. So there are things like that out in the community to help keep people hydrated. But if you keep someone hydrated, you can help reduce the risk of delirium. Also feeding, encouraging them eating, setting it up for them if needed, and feeding assistance if needed. Then mobility, ROM, what does that stand for? So many acronyms in the world of medicine. Here's one more. Range of motion. Thank you, Anne. Range of motion. So that's just lifting your arms as high as you can, putting them back as far as you can, just range of motion exercises. Sometimes they get like big rubber bands and they use those to do their exercises. Mobility. Here's the first time we've talked about this, walk. So mobility is a big, big issue for elderly people, and it can help reduce the risk of delirium. Chair stands, exercises, and WEE. Does any of the hospitals use WEE as part of your physical therapy? No. I've seen several NH use, not for inpatient. No. So it can, they have Wii bowling, different things that in some hospitals, they use it a lot for kids, probably more than adults, but it can work for adults too, to keep them up and moving. And they can do that in bed with their arms, some of the games. And then relaxation during the daytime can help prevent delirium. Hand-foot rub, you can have volunteers, encourage family to do foot rubs and hand rubs. And then sleep, making sure you have good sleep hygiene. If they're sleeping all day, then guess what? They're going to be awake at night. So try to keeping them busy during the day, and then so they'll get a good night's sleep. You can bring in different things like relaxation tapes or music. Okay, we can go to the next page, a little bit more about delirium. So delirium, such a difficult condition to deal with that some hospitals have found that patients benefit if they have a specialized room set up for them. So they have specialized care delivered in a dedicated room for the disoriented patients. And the benefit is that you can avoid using restraints. You can have a bed on the floor, so a low bed. You don't have to use as many medications that will kind of reduce their symptoms. These delirium rooms can offer a viable option for caring for delirious patients. Does anyone have a room for delirious patients at their facility? Got a no from Jamie. No. So I'm guessing probably at a larger facility, it'd be much easier. At smaller facilities, it'd probably be a lot harder to have a room dedicated. But you can also take a room and make it a room for someone who's bring in a bed that's on the floor and bring in different interventions to help. So that's delirium. It's one of the other adverse outcomes that someone who's older is at risk for when they're hospitalized. So let's go on to the next one, and that's pressure ulcers. So a good way to fight pressure ulcers is good nutrition. Protein intake. That really is something for wound healing. I worked on the burn unit for 6 years, and as soon as someone came in, we started tube feeding them, whether they could eat or not, to supplement their protein intake for wound healing. So that's what a pressure ulcer is a skin wound. And for that to heal, or for skin to be viable and good enough not to get an ulcer, then you want good nutritional status. You do not want them wet in bed. Someone laying in a wet bed from incontinence, that puts them at higher risk for skin ulcers. Immobility, not moving them. Who out there can tell me what's the maximum amount of time we would let a patient lay immobile? Maximum amount without moving them. I know the nurses will know. Talk amongst yourselves, guess amongst yourselves, and then anyone want to type it in? 2 hours, unless end of life, then maybe less. Good point, yes. 2 hours, that's exactly the right answer, is 2 hours. So that's the maximum amount. When someone is older, you want to move them more often than that, unless they're at end of life, and then you may not necessarily need to move them because it makes them uncomfortable. But if you're getting someone to recover from something, you want to move them so that the pressure isn't on a bony prominence, so that's the elbow, the heels, the lower back, and especially those people with neurologic impairment. And who would that be? What condition would they have that would cause neurologic impairment? There's a couple out there, but I'm looking for one specific. Strokes, okay, good. They can't move themselves. I'm looking for, that's the right answer, but it's not the answer I was looking for. I'm looking for the inability to feel. So numbness. Who would have numb heels? Diabetes, there we go. Ding, ding, Dixie Doherty wins the prize for diabetes. Right, so someone who has diabetes, that, especially if they're older and it has been uncontrolled, there's a good chance that they have a numbness and tingling or complete numbness in their extremities. Meaning that if you and I laid and watched Netflix all day, which I have done, if you did not move from that position on the couch and your heel was pressed, and maybe you've done it, you've laid in one place long enough, it hurts, you feel it. And so that is a signal to your body to move. Someone with neuropathy, which is numbness of the feet, will not feel that pain. So that puts them at a higher risk for pressure ulcers on the heels, on the sacrum, shoulders, and elbows. Another strategy to reduce pressure ulcers is to assure 3 layers or less when sitting in bed. Do you mean 3 layers under them, or 3 layers of sheets, or does that count as a bed? So 3 layers under them, right? So don't have bulkiness underneath them that has different pressure points. Thank you, Lana. So the pro here is optimizing nutritional status, and limiting time spent in one position can help prevent ulcers. And I'll tell you, on a busy unit, when a nurse has 5 or 6 patients, they are not always going to have the time to turn someone every 2 hours. That's where our nursing assistants come in, and they're like, I worship them, because they are really the ones that keep our patients safe, and especially the elder ones. So if you don't have something in place, then you should. So that completes the different types of adverse conditions that can come about when an elderly person is hospitalized. Now we're going to talk about a few models of care that can assist you. Some of them are very simple implementation. Some of them you have to bring someone in to train, but we're not even talking about all of them. There's lots of them out there. There's a slide here that includes many of them. I'm going to talk about 5 or 6 models of care. So a model of care is just a good way to deliver services for older people. So several models of care reduce readmissions and emergency department visits, improves patient satisfaction and outcomes. Gerontological experts use evidence-based elements to formulate models of care for elderly, and what elements can be modified for use in your facility. So think about this as we go through these different models of care. And I'm also going to ask you what models of care you may be familiar with some of these, and see if you can kind of share with us all what you've implemented through these models. So let's take a look at a few of the models. We can go to the next slide. So ACE stands for Acute Care for Elders. Let me just get my notes here in front of me. So the inpatient unit is specially designed and staffed for older patients. There's no accreditation or firm definition for the model of care. So it's a special unit that's put together, that's an age-friendly environment. You have an interdisciplinary care team. So you have a social worker, you have the nurses, you have a provider, either a nurse practitioner or a physician. And then DC planning is part of the care. DC planning for elderly can be is very important, because sometimes we have patients, I think this says in a later slide, like over 85, who don't just go home, like you and I probably would just go home and recover. They go to a secondary skilled nursing facility, or a SNF, which means then their medications are sent from one care team to another care team, and that care team has to interpret that. But they had medications when they started at home. Now it may be different because they're coming out of the hospital. They get to the SNF, and then that provider reviews the medication, doesn't know what was taken out of, so it can be a big mess. So the discharge planning for an elderly person that's going to SNF has to be really focused on. And then of course the care is patient-centered. So what this is not, this isn't a procedure you can bill, this isn't a DRG, it's just different, it's an environment where you can reduce risk for all of these conditions we talked about, and perhaps save money in the long run by reducing readmission. So one thing, for example, DC planning for plan of care, you may want the social worker to ensure they can buy groceries when they get home. I mean, it's something as comprehensive as that when you're dealing with someone who's 83, or are they going to be able to cook for themselves? And you need to ensure all those things are in place, or else you're going to see them back in a week. All right, we can go to the next slide. And then more about this, the hospital can be a hostile environment for elderly patients, create a safe and age-friendly environment. And these are some things that we talked about: add handrails in special locations, large clocks so they can see what time it is, large font for all printed materials, elevated toilet seats with a different colored toilet seat. I really like that idea. And door levers instead of handles or knobs so they can just push or pull. They may not have the dexterity needed to turn a knob or turn a handle, so they can just push against it or pull it to open and close doors. It's not always possible in an environment where you've already had the rooms built, but these are things that could improve if you were to. And then a little bit more about the acute care for elders. It's an interdisciplinary team, as I said, and it addresses gerontological syndromes and issues. So this is where you think, what would a geriatrician do for this patient? Patient and family conferences. You want everyone there, you know, the nurse, physical therapist, occupational therapist, pharmacist, dietitian, social worker. So the ACE unit coordinator, I see that probably as like the charge nurse or someone that kind of oversees everyone, and a geriatrician. And don't forget the chaplain. That would be a great person to also bring into these this type of setting. So you want them sitting down every day and planning for each patient and talking about their needs and their discharge plans. And then address elder care issues. Polypharmacy, what does that mean? Anyone out there want to jump in with polypharmacy? So it's spelling and definition test today. So an elder care issue is polypharmacy. Who has multiple medications? Tons of meds, exactly. So I was going to say, who out there has parents that you have to set their medications into a pill box because they take 6 in the morning, 2 in the afternoon, and 3 at night? So there is no firm definition of what is too many pills, but in a nursing home, we say anyone taking more than 9 pills a day is potentially at risk for polypharmacy. And polypharmacy just means they're at risk for medication interactions, and that what they're taking can interfere with each other. So that's an issue that you can address while they're in the hospital. Delirium, dementia, failure to thrive. That's when someone isn't feeding and eating themselves enough to stay healthy. And then you have elder abuse and neglect. You can discuss malnutrition and depression. So rural hospitals in Wisconsin that do not have a geriatrician on site. So for those of you who said they don't have a geriatrician and only have hospitalists, this is something that they did in Wisconsin. They use a telemed to support the ACE concept by connecting with geriatricians located in Milwaukee. And in the future, it can be beneficial to meeting the MACRA requirements. And I had to look MACRA up because I wasn't sure what it meant. So let me tell you what it means here. Sorry, let me get my notes. MACRA is, sorry. Here we go. It's a law passed in 2015 to create incentives to advance value-based payment. So if you keep someone healthy, you get paid better. Clinician payments based on performance and quality metrics. So this may help in the future. So, and it's an idea for those of you who don't have that, is perhaps there's a geriatrician in the next county who would telemed in or who would work with you on a consultative basis if you have issues come up. We can go to the next slide. So to reduce functional decline, so patients get moving. Remember I said walking, that's the first time we talked about it. But here it comes again. So modify the environment to encourage mobility. That means in their hospital rooms, you make enough space so they can get up and walk in their room. You gotta move everything out of the way. They can get up and you encourage them to. You encourage them to walk to dining. So this is a great thing that's done in nursing homes. You have a communal dining room where you encourage people to get up and walk to and from their meals, hallway, or you might, in a hospital, you encourage them to get up and sit in the chair in their meal, for their meal, as opposed to sitting in bed. Hallway is not the only place for walking. Like I said, you can clear the room, and then minimal use of catheterization and sedative hypnotic drugs. Reduction in falls through mobility. So this is getting people up and moving, and it's kind of counterintuitive because you think, oh, the more they get up, the more likely they're going to fall. But really the opposite is true. By getting them up more, they build their strength, and then ACE units decrease the number of falls. In 2006, they had 48. 2009 down to 25, and then 2012 down to 13. So there's a website there. We're not going to go into the website right now. We got 15 minutes here. I got a few more things to talk about. So functional decline health. Immobility is associated with increased risk for falls, delirium, skin breakdown, and venous thromboembolic disease. What is venous thromboembolic disease, anyone? Easy answer. Anyone? Venous thromboembolic disease. Blood clots. There we go. Dixie Doherty wins again. So that's a fancy way of saying blood clots. So getting them up and moving puts them at reduces their risk of blood clots. Helps prevent falls, as we talked about. And then even ventilated patients in the intensive care unit can benefit from early mobilization programs. On the burn unit, when I worked there, we would have ventilated patients, and we would affectionately call it bag and drag them. So you would get them up, and you would take them off the ventilator actually, and you would bag them, and they would walk. But it really is helpful to decrease falls for elderly, and it helps the muscles, helps the lungs, helps digestion, everything. We can go to the next slide. So we just talked about ACE, the acute acute care for elders. Now we're going to talk about HELP, another one, Hospital Elder Life Program. So this is a resource for clinicians, other hospital people, family members, and patients. In this website, why don't we go to this website? And this specifically is about delirium prevention. So what's great about this website is that you can get families involved. A lot of times families see their family member delirious and they can't believe it. This is a great resource to send to them about things they can do. If you can help them feel like they're doing something or that they have some knowledge to work with, it really can help with families. So there is information on this website, and it tells them things like, make sure you bring a comprehensive list of their medications so we know all the meds are on, because we know that might be one. I don't know if it's not going to pop up. And then things like bring their glasses, bring their hearing aids, their dentures, bring familiar objects from home, pictures, their favorite comforter. So it tells things that family can do to help with the situation that would be supported through the medical staff. So it also, you can train volunteers for health interventions. So within your hospital, if you have a volunteer program, this is a great tool to train them on so that when they are working with patients, they can provide information about helping elder patients. It doesn't look like we're going to get there, and that's okay. We can go back to the presentation. So we are on, we can go to the next slide. So increases patient and family, which one are we on now? Recognizing delirium. So Hospital Elder Life Program. So these are, it'll help not only family, but healthcare providers to see what is delirium: inattention, disordered thinking, jumbled thoughts and rambling speech, altered level of consciousness, changes in personality. Sometimes you don't know someone is delirious because they stop speaking. So you can, they don't verbalize as much, but if they are verbalizing, you pretty much can recognize delirium. So there are assessment and screening tools. The CAM, there's many different versions of that. There's a ICU version, an emergency department use version, a primary care version. So this is the confusion assessment method, and that's what's used to identify delirium. And then for interventions, daily visit interventions and other non-pharmacological treatments. So besides drugs, you can have people come in and see them every day, and then ask your medical staff to implement specific delirium care guidelines for your facility. So if someone is diagnosed with delirium, then you implement specific protocols. We can go to the next page. So that's HELP. We talked about ACE, we talked about HELP. Now we're going to talk about, can we do a poll here? Is there any way to do a spontaneous poll? Because is this niche or niche? Because I call it niche, though I've heard niche. So spell it out, N-E-E-S-H or N-I-T-C-H on what you think it is. Niche. Lana, I'm going to go with that. Since Lana said it first, we'll go with niche. So niche is Nurses Improving Care of Health System Elders. This is a program for nursing. It is something to really, it works to get elder care into the fabric of the hospital. So you train the nurses, they become niche nurses, they sit at the table at meetings, they go, to organizational meetings, into planning meetings, and they advocate on behalf of the elder patient. So it provides tools for best practices to manage pain, prevent pressure ulcers, adverse medication, delirium, falls, and the management of urinary incontinence. It can be implemented in hospitals, long-term care, and home. We're having some connection delays, so I'm going to stop here for a minute. Please see the list at the top of the chat to navigate the resources. So that website she was trying to go in at the very top of this chat, they listed all the different websites for all these different models so that you can have those if you want to go in and look into them. So does anyone out there have the niche program in their hospital? No, double no. They do have it at UIHC here, University of Iowa Hospitals and Clinics. And it's like I say, it is a nursing program, and it might be something that you want to look into because there's not a lot of money that needs to be spent as far as changes in bed or putting up grab bars, but you get someone there that as time goes forward, they advocate for things that are elderly friendly. And it's a really great program. So let's talk a little bit more about on the next page. So designated nurse to be the facility's geriatric expert. You can subscribe to these journals. You get the evidence-based content, all these different journals. Bring older adult care topics to regular staff meetings or huddles, like I said. Encourage use of facilities' educational benefits for higher learning in geriatric degrees, and provide nursing CEUs on geriatric topics. So it kind of highlights or brings geriatrics to a voice. It gives geriatrics a voice in your hospital, this niche program. And next slide, a little bit more about it. There's also an app, Niche for the Family and Patient. So prep for transitions between home hospital and long-term care. It can niche translates, encyclopedia, going home and checklist. So it gives the family, once again, a tool that they can use to ask the right questions, to make sure that they have everything they need to get their family, their elderly family member home safely and keep them home. And then the next one, we got a couple more, and I'm going to go a little bit quickly through these. So if we can go to the next slide, Care Transitions Model is what this is called. And this is a model by Dr. Eric Coleman, and it's all about patient and family empowerment. So what they do is they train, you have to hire them to come in for a day and a half of training, and they train your staff to be transition coaches. And these transition coaches then work with the families and the patients to empower them to really make them take responsibility for asking the right questions. There's not a lot of cost involved once you get the training out of the way. So it says so the training is a day and a half, but the program, when you implement it, is a 4-week program consisting of 1 home visit and 3 phone calls. So through those interactions, you help the family keep the patient at home and well. We can go to the next slide. Also, I couldn't find the cost for the training of that, so you would have to type in a message to them. So this just tells you what the transition coach does. It encourages the family and caregiver to assume a more active role, doesn't fix problems, doesn't provide skilled care, but facilitates with role plays and different things, how they can communicate better with the medical staff and amongst each other. And we can go to the next slide. And the checklist of interventions that could be used. So medication management, personal health record, medical follow-up, red flags, other. So I bet all of you already have this in place for your discharge planning, but it's a comprehensive tool that kind of organizes it for you if you don't have a real organized discharge planning. So this is the care transitions model, also known as the Coleman model. And we can go to the next page. And we're just going to touch on discharge planning. So as I mentioned earlier, discharge planning for older patients, they're much more vulnerable. They're more vulnerable to medication errors, because I'll tell you, ask someone who's older, what medications do you take, and what is the answer that you get? Sometimes. Any of you, any of the nurses? I take a blue pill in the morning and a yellow pill at night. So they're not always really great historians of their medication that they take. So in your discharge planning, you need to make sure that it's all there with the names, any changes that occurred, so that they know not to go back to their regular routine when they get home. 40% of patients 85 years old and older are discharged to skilled nursing facilities or SNFs prior to going home, which adds to a second transition and a third set of care providers, as I mentioned earlier. And there are programs out there developed to improve the hospital discharge, including Boost and the care transitions program that we just talked about. We're not going to talk about Boost, but the website is there. We can go to the next one. We have this impact. This is a collaborative care model, and this was created at the University of Washington in their psychiatry department, and it's under the heading of AIMS, which is Advancing Integrated Mental Health Solutions. So we had one that we talked about that was for delirium, addressing delirium. This is for addressing depression, and what this is a great model where the primary care collaborates with the psychiatric mental health provider and a case manager. So there's kind of three people working together to make sure that depression is addressed in elderly. In the elderly, we can go to the next page. They treat the whole person, both medically and behaviorally. And so the primary care provider refers and prescribes the antidepressant medications. They consult with the psychiatrist, who kind of gives them the diagnosis and make sure everything is going. If it's not improving, then they'll see them, and then the depression care manager educates the patient and makes sure they don't fall through the cracks. So they use the PHQ-9. This is something you give to patients to fill out to facilitate the diagnosis and track the depression. And there's resources for that. So we can go to the next page for impact, identify depression, ensure proper follow-up, and be aware. So this is a great program for, especially in Iowa, we have really big challenges with mental health. So even taking part of this and getting your psychiatric mental health people talking to your primary care, so that the primary care isn't automatically referring to the psychiatrist, will help keep people out of your hospital. They'll help keep them from being hospitalized. And we can go to the next one, which is palliative care. Who does not have palliative care? Oh gosh, I got 2 minutes here. So I'm not going to wait for your answers. Palliative care, the difference between palliative care and hospice is palliative care, the person is still being curative, has curative treatment going on. Hospice, they can also, but it's usually not as much. So palliative care is something I encourage, if you have it, I encourage you to increase the use of it, especially with the elderly, so that we can get, we can go to the next slide. We can get people filled in on their end-of-life paperwork. More about palliative care. Let's skip the next slides. This is all palliative care. We're going to skip through it. I think this is probably most familiar with you. But the slides are here for you to look at. And then the next slide should be, let's just stop here real quick. Well, no, let's stop here. That's fine. We're fine. Other models of elder care. So these are the ones that we haven't talked about. Include some we have, but others we haven't. So you have those lists. And then if we go to the next page, I just want to touch on 2 more things and then we'll be done. Thank you for letting me just go on a little bit. Grace, this is the last one we're going to touch on. And the reason we're touching on it is because on the next call that you have, you're going to have representation there from this program to come and talk to you about the geriatric resources for assessment and care of elders. So you'll have actually the people who implement that. And we can go to the next slide. So there's a website there. It's from Indiana, and you can look at it before you talk to them. And then I think here I can turn it back over to you, Kate. I don't know if we have time for questions.
That sounds great, Larry. Thank you so much for your time today. At this time, we would like to open it up to any questions for Larry. And I know we're running tight on time and starting to have a couple people drop off. If you do have questions or your team comes up with some questions after reviewing this presentation, we would encourage you to start a thread on Innovation when this presentation is posted, and we'll answer those questions and certainly bring in Larry to help answer questions that may come up on that thread. There is one question coming in, Larry. What words should be used? Elder, geriatric, senior citizen, what's most appropriate?
Yeah, that's a really great question, and I think it changes. My take on it is geriatric is a term that I avoid using. I don't think it kind of represents, or it kind of has a background meaning of someone who's old and crotchety. So I like to use elder or older person. Senior citizen is probably something I don't use because there's it's kind of associated with a discount, senior citizen discount. But I use gerontological when I'm talking professionally, and I usually use older, elderly or older adult when I'm talking about people over the age of 65. There's nothing wrong with using any of those terms. Just for my preference, I like older adult, elder, that type of thing. That's a good question.
Great, thank you, Anne. Thank you, Anne. Well, in wrapping up, I do want to remind you of what's coming up in August. August Readmission and Care Transitions COP is on Tuesday, August 22nd. We'll continue our last session of the Age-Friendly Health System Summer Series. And as Larry implied, we do have some representation from the GRACE team, and they'll be overviewing that model of care, providing some of their tools to our group here. We look forward to that. Again, if you have any questions or comments, please do send those via email or phone call to myself. We look forward to seeing you next month, and thanks for joining us.
Thanks all.